Today, we're talking about why echocardiography has become the quiet backbone of cardio-oncology and why that matters now when more people are surviving cancer and living with long-term cardiac risk. I'm joined by Professor Arjun Ghosh, who's built these services on the ground, someone who's seen how imaging decisions change treatment pathways in real time. The stakes are practical. After listening, you should understand what actually needs to be measured, when, and how service design can reduce delays and disruption for patients. So let's start simple. Why has transthoracic echocardiography become the workhorse here?
It's because you need something repeatable, accessible, and sensitive to change. And Echo does that before, during, and long after cancer therapy. We're watching for cancer therapy related cardiac dysfunction, which often starts subtly, and Echo lets us track that longitudinally without adding burden.
You're talking about subtle change. What are you actually looking for before the ejection fraction drops?
Global longitudinal strain, or GLS, is key because a relative reduction of about 15% can appear before overt systolic dysfunction. Diastolic changes can also come first, and right ventricular measures matter depending on the therapy exposure.
That sounds technically dense, but for a clinician running a busy service, what has to be non-negotiable in a cardio-oncology echo?
You need consistent LVEF measurement, ideally three-dimensional strain analysis, and a structured look at diastology, RV function, valves, pericardium, and pulmonary pressures. And if image quality is limited, contrast should be used rather than guessing.
Guidelines recommend frequent surveillance during some therapies, but that can overwhelm services. So how do you make that feasible?
By changing delivery rather than lowering standards, and that's where one-stop clinics help. Same-day echo and cardio-oncology review reduces visits, avoids treatment delays, and gives oncologists answers immediately. We were also the first to introduce focused echoes, which speeds up repeat scans.
You've embedded echo directly into oncology pathways, including lymphoma clinics. What did that actually change?
It shortened time to imaging to a median of 5 days, and only about 1 in 10 patients needed escalation to cardio-oncology. Most had normal systolic function, though diastolic abnormalities were common, and catching issues early avoided last-minute therapy changes.
A lot of this relies on physiologists taking on expanded roles, and some clinicians worry about safety. Where's the line?
The line is protocols and escalation, not autonomy without support. Physiologist-led clinics work when training is formal, abnormal findings trigger immediate review, and quality is audited continuously.
You've applied that model to survivors treated young, years after therapy. What emerges there?
About a third had findings or symptoms needing further workup, including borderline LV dysfunction that led to closer follow up or additional imaging, and some needed support beyond cardiology, like psychological care.
So, if demand keeps rising with newer cancer therapies, what actually needs to change next?
Flexibility and workforce development because the imaging itself is established, but services must adapt to volume and complexity without fragmenting care.
What connects everything we've discussed is that cardio-oncology echo isn't about more tests. It's about the right measurements done at the right time in systems designed around patients' lives. Thank you for walking us through that. And for those listening, the takeaway is simple. Good imaging doesn't just detect harm, it protects continuity of cancer care, which is something every patient depends on.